Would you like to run medical simulations within your hospital, but you're worried about the practicalities of organisation? Do you struggle to multitask during a sim? Or do you find Debrief awkward and difficult? I'm Dr. Matthew Sayers, a consultant paediatrician, and I run regular medical simulations for PEDS trainees and medical students. In this video, I will share my tips on how to make your medical simulations run effectively. Planning is one of the most important things in designing a sim, and it is important to consider the following factors when designing a successful sim. Who is the sim aimed at? How much knowledge and experience will they have on the topic, and how familiar and comfortable will they be with sim? This will help you pick appropriate learning outcomes. Is your sim going to be multidisciplinary, involving nurses and other staff? This can be very helpful to bring out teamworking and communication skills, but consider involving staff members from these disciplines within your faculty team so they can help you with sim design and feedback to these professionals. What facilities and equipment do you have available? If your hospital or facility has very advanced simulation equipment and trained staff to help you facilitate, more advanced and complex scenarios can be designed. Do not be put off if you have only basic or no equipment, however. The key to a successful sim is good scenario design, not the equipment. When will you run the sim? It can be challenging to facilitate a time to set up, run, and debrief the sim, as well as taking staff away from their designated clinical duties. It can be helpful to involve the ward consultant, nursing sister, and rota organizer to find a time that best balances staff availability and workload. Where will you do the sim? In situ sim, in which the sim takes place in a normal clinical environment, has the advantages of increased realism and a wider access to the multidisciplinary team working in their own clinical areas. However, it can be challenging to facilitate on a busy hospital ward where there are patients and relatives, limited space, and other pressing clinical duties. If you are doing an in situ sim, always make sure you make senior members of the team aware that you're doing it. Sims that take place in a designated clinical area or sim suite have the advantages of reduced distractions, more space for observers, and less setup time as all the equipment stays in one place. However, they can feel more artificial, and it can be difficult for some members of staff to leave their clinical areas to attend these sessions, particularly for nursing staff. If you're not sure what would work best in your area, experiment with different types and seek feedback from the learners on which works best. Finally, and most importantly, why are you doing the sim? i.e., what are your learning outcomes? Think about what knowledge and skills you want your learners to take out of the sim, as this will help you design your scenario around this. Think about both technical and non-technical skills. Technical skills could involve managing a particular condition or performing a particular procedure. Remember who is taking part in the sim and make sure you design your learning outcomes appropriately for them. A scenario designed for a medical student would not be challenging for a senior registrar in the specialty, and it is important that the sim appropriately challenges the learners if they are to engage fully in it. If nurses or other staff are included in the sim, try and involve a senior member of their team within the faculty, as it can be challenging to identify appropriate learning outcomes for these groups. Once you have answered these questions, you can start the practical process of organising your sim. You should start this at least 1 week before you plan to hold it. The first step is to pick a date and time for your sim that will maximise attendance of the faculty, the learners, and for observers. It can be helpful to chat to your local rota coordinator to pick a suitable date and time that will maximise attendance of participants. It can be helpful to involve a senior doctor as a participant within your simulation, as most complex emergencies will involve discussion with a senior doctor remotely. The senior doctor can also take on the role of a specialist referral centre or a subspecialty team if you want your simulation to involve these teams. Make sure you get the agreement of the senior doctor to take part before the simulation, and make sure they understand their role within the sim. Contact your faculty with plenty of notice to ensure you have sufficient help to run the sim. Once you have confirmed a quorum of participants and faculty staff, you can then decide whether you want to publicise the sim or not. Personal preference on this varies, with some preferring an unannounced emergency call. However, this can cause annoyance for participants and makes it harder for observers to attend. My personal preference is to schedule the simulation as protected teaching time, with participants assigned and sufficient notice given for observers to attend. You should also contact your sim suite or equivalent to ensure that the equipment and facilities are reserved for you at your chosen time. You can now design your sim based on your learning outcomes. You will need a detailed history, clinical examination, observations, investigation results, and management plan. It can be helpful to use template scenarios which you can adopt to make them suitable for your learners. There are a number of organisations that have designed template scenarios, and I will link some of these in the video description. It can also be really helpful if you have encountered interesting cases in your clinical practice to include these as scenarios. Reality is often stranger than fiction, and it can add greatly to the engagement of the simulation if you are able to use anonymised real investigation results and imaging findings in the sim. It is important to be very familiar with the optimal management of the scenario in case you're challenged during the scenario or debrief. So it can be helpful to read important local or national guidelines or key papers on the topic beforehand. Always remember to have the patient's weight recorded and calculate some of the common drug doses so that you're able to quickly check the participants' prescriptions during the sim. On the day of the sim, remind the faculty, observers and participants where and when the simulation will take place. Check with a senior doctor and nurse on duty to ensure that the clinical workload will allow it to run safely. It is very important to prepare all your equipment in advance of the simulation, as equipment failure is common and it can be very time consuming to do this. Give yourself at least 30 minutes to set up. Ensure you have all the key resources available for your participants, particularly a drug card X, fluid balance chart, observation chart, and BNFC. Also ensure that all the key equipment is immediately available, including an oxygen mask, nebulizer mask, saturation probe, ECG leads, blood pressure cuff, cannula and blood bottles, and a blood gas syringe. I would also keep a training EpiPen and training buccal midazolam syringe, as well as flushes and water for injection vials labelled with the reconstituted medications that will be required in the scenario. It can also be helpful to print out learning resources such as Research Council guidelines or relevant clinical papers to give to participants and observers to cement their learning. Always remember to print out feedback forms to give to the participants and observers after the simulation as well. Now you will need to set up your equipment. If you are leading debrief in the sim, it can be helpful to have another person controlling the mannequin. If this is the case, make sure that person is familiar on how to adjust the clinical parameters on the mannequin. If you're doing an in-situ sim, you will have to set up all your equipment in the clinical area, so give yourself more time to do this and to troubleshoot. Make sure that patients and service users know what is happening so they are not distressed or adversely affected by the sim. If you have observers, you will need to think how many you can accommodate and where they will stand so they are not in the way of the sim and also they can see and hear clearly. Your sim suite may have AV facilities which allow virtual attendance. If not, a mounted mobile phone with Zoom enabled may be an alternative. Around 15 minutes before the sim is due to begin, brief the faculty on the scenario and what is expected of them and their roles. Ideally, you will have 3 additional faculty members. 1 to act as the parent or relative, 1 to manage the equipment and provide clinical information when requested, and 1 to assist you in debrief, ideally a senior nurse or allied healthcare professional in the case of a multidisciplinary sim. If the faculty are experienced in sim, this can be straightforward, but allow more time if there are inexperienced faculty taking part. Make one final check of the equipment, and finally, your sim can begin. If you're doing an unannounced sim, you can use emergency buzzers or bleeps and allow whoever attends to manage the sim as they find it, but it would be preferable to offer a briefing to the participants first to maximise their understanding and engagement. Introduce yourself and the faculty and explain your roles. You should explain that simulation is a safe environment, it is not an assessment, and that they should act in the exact manner they would in their normal clinical roles. They should take a history from the parent and assess and manage the mannequin as much as possible, rather than asking or telling the faculty what they would do. Give them a short introduction to the scenario, and if there is a cardiac arrest as part of the scenario, advise them of this in advance, as participants often feel that it is their poor management that has led to this occurring. Also remind the participants that if they are calling a doctor or team not part of the simulation for advice, to preface their phone call by explaining that this is part of a simulation, so that this team doesn't believe that they are giving advice to an actual patient. During a simulation, it can be very hard as the leader to follow all aspects of the simulation and discussions and remember these to provide feedback, which is why the more faculty you have to assist you, the better. Always be ready to step in if there are equipment issues, unclear aspects of the scenario, or the participants are becoming very distressed. If a member of the sim is distressed, it can be a good idea to pause the sim for a few minutes to allow them the opportunity to recover. If they remain very distressed at this stage, they should be excused from the sim, and a member of the faculty or a senior observer should take them out of the room and support them. It can be very helpful to make notes on any good or bad aspects of care that you note during the sim so you can remember this for giving feedback. Run the scenario for a specified duration, usually 15 to 30 minutes. Make sure you have a clear termination. It can be helpful to have the arrival of a senior doctor with an associated S-bar handover as a natural transition. Be positive and congratulate the participants on their performance. Make sure they have somewhere to sit and refreshments are available. Give them a few minutes to recover before starting your debrief. The purpose of debrief is to identify and consolidate learning that can be applied to clinical practice. There are a number of useful debriefing tools that can be used. My personal preference is the PEARLS method, which I will discuss now. Always remember that your role is to facilitate discussion, so try and speak as little as possible and encourage the learners to do the bulk of the discussion. Firstly, you should set the scene. This transitions the learners out of the simulation and into the debrief and creates a safe learning environment. In this, you state the purpose of debrief and its assumptions. I would say something like, we are now going to spend some time debriefing the sim so we can apply our learning to our clinical practice. You've done a really great job, and I'd love to hear how everyone found it. The next step is reactions. This focuses on the emotional reaction to the sim, which is particularly important if the learners are distressed or angry. Ask an open question like, how are you feeling after that, which invites an honest and emotional response. Use active listening and observe body language to gauge the learner's feelings. Validate them and provide support. Don't move on to the clinical aspects of the sim until you have addressed the emotional aspects. Many learners are very self-critical and despondent after a sim, so it is important to restore their self-confidence before you mention any constructive improvement, or else it will be interpreted as criticism and failure. Whenever the learners are naturally moving on to the clinical aspects of the sim, you can move to the next step. The next step is description. In this step, we clarify the facts about the case before we go on to analyse it further. It can be helpful to ask one of the learners, could you summarise the clinical findings you made in this case and how you managed them? Involve other learners in this discussion and also observers so that everyone has a shared understanding of the case before we go on to analyse it further. We now move on to analysis, which should be the bulk of the debrief. In this step, we look at the clinical and communication aspects of the sim and try and identify learning points and improvements. The key areas to look at are decision making, knowledge and technical skills, communication, resource allocation, situational awareness, leadership, and teamworking. If you have made notes on these during the simulation, this can be very helpful. You can ask a question like, what do you think you did well? Or, is there anything you would do differently if you were doing the sim again? Involve other members of the team and observers, as everyone will observe different things depending on their perspective. A useful way to identify learning points is to use the phrase, I saw you did this action, why did you do things that way? If there are knowledge gaps or incorrect clinical information, you should address this by saying something like, next time you should consider doing things this way, and we are doing this for this reason. The final step is application and summary. This is really important to cement the learning points in the learners' minds. This can feel a bit cringy, but I find it's very helpful to ask everyone in turn, including the faculty and observers, for one learning point each that they will apply to their clinical practice, which forces everyone to engage with this step and generates a lot of learning points, which can be very helpful. Thank everyone for taking part in the sim and consider giving out feedback forms so you can learn how to improve your sims. These are also very useful for portfolio and appraisal. You should consider how you will share the learning from your sim more widely with the team, perhaps sending out an email or newsletter with the key learning points identified. Hopefully this video has given you the confidence to run sims in your hospital or practice. The best tip I can give you is just do them and learn by trial and error. Don't feel it has to be perfect, and always make them relaxed and fun. Thanks so much for watching. Please like this video, comment with any clinical questions or feedback you have, and subscribe to the channel and our other social media accounts including Instagram, Twitter, Medall and OLAS to stay up to date with future videos. I look forward to seeing you again soon.